how to approach a painful diabetic neuropathy. And for that, we have very eminent speaker with us, Dr. S K Somani, who is a founder member and member of Scientific Affairs of HDS. He is a very senior and reputed neurologist of Howrah. For him, we have chairpersons Dr. Buddhadev Mukherjee and Dr. Deepak Kapoor. Talking about Dr. Buddhadev Mukherjee, one of the senior-most medicine consultant who is attached to Narayana hospitals. And we have Dr. Deepak Kapoor with us, who is a physician practicing more than 30 years in Howrah. Sir, speaker sir, chairpersons, I welcome you both on stage.
Thanks to the organizer for giving me an opportunity to chair this session. Now, as you all know, the diabetic patient, they produce so many complications. And that is why the disease is so serious. And you see, the neuropathy is one of the complications of diabetes itself. As you all know, it produces the painful, symmetrical, sensory motor, and also to some extent it is due to vascularity and also uncontrol of diabetes. This painful neuropathy is produced. Now, the subject will be discussed by no less than Dr. Somani, who is a renowned neurologist here and also in Howrah. And most only, I am very glad to see Dr. Somani, as because we worked in the same unit and in the Calcutta Medical College for several times, and now I find that he is a speaker and it is very glad to me. Thank you.
Yes, sir. I was a house physician when you were the registrar, sir. My topic is approach to a painful diabetic neuropathy. I tend to keep it clinical, avoiding references to elaborate guidelines and research papers. Diabetic neuropathy in all its different forms is one of the most common long-term complications of diabetes, affecting about half of the population of diabetes. As the burden of diabetes is increasing globally, so diabetic neuropathy and by extension painful peripheral neuropathy is also increasing. It is estimated that about 16% of diabetes mellitus patients and half of the diabetic neuropathy patients have painful diabetic neuropathy, which is increased healthcare burden, reduced quality of life, loss of productivity, and greater risk of diabetic foot disease. These are the well-known modifiable, non-modifiable risk factors for diabetes. Degree and duration of diabetes and life cycle factors are the most important ones. Given the fact that half of diabetic patients have diabetes, the other half don't, genetic factors are also being looked into. These are the common signs and symptoms. In neurology, we talk about positive, negative signs. Pain is mediated by small fibers, which mediate sensory and autonomic symptoms. Tingling, pins, needles, burning, etc. are the positive features of sensory neuropathy. These are the pain descriptors. Patients may describe pain as tingling, burning, shooting, pricking, current-like. For scientific discussion, we use several terms. Spontaneous pain, when pain is there without any stimulus. Allodynia, when pain is there because of harmful stimuli such as touch of the bed sheets, movement, cold, heat. Similarly, paresthesia is abnormal sensations, either spontaneous or evoked, such as tingling, buzzing, vibrating. These are the symptoms of painful neuropathy. While taking history, one must be on guard, especially to rule out non-diabetic causes. Of these, when a patient presents with a family history, or when a patient has purely motor symptoms or motor symptoms out of proportion to sensory symptoms, or selective small fiber involvement only, or deformities of toes, pes cavus, hammer toes, or arch deformities, one should be on guard. These are the differential diagnoses of these: vitamin B12 deficiency, alcohol, drug-induced. Metronidazole is frequently used for recurrent hemibiasis and is known with neuropathy, which may be painful. Similarly, nitrofurantoin used for UTI is, when prolonged, is also associated with painful neuropathy. Other causes, among other causes, peripheral vascular disease and rheumatologic disease should also be looked into. And the confounding thing is that these may coexist with diabetic neuropathy. Next, I come to classification. Diabetes mellitus, diabetic neuropathy in all its different forms have different pathology. They respond differently to drugs, and they have a different natural history. Some acute painful neuropathies and symmetric neuropathies, of which sensory or sensory motor neuropathy is the most common, and focal neuropathies are cranial neuropathies, mononeuropathy multiplex, entrapment neuropathies, and asymmetric lower limb involvement. I'll come to them one by one. Of the two important acute painful neuropathies, hyperglycemia, uncontrolled, poorly controlled hyperglycemia of long-term duration may be associated with severe pain, especially in the distal extremities, but there may be sharp shooting pains proximally also. These sensory symptoms develop in a poorly controlled diabetes patient. There are lack of objective signs, that is to say, symptoms are more prominent, signs may be minimal or absent, and it is associated with severe weight loss. And Ellenberg coined the term neuropathic cachexia to describe. But the good part is that with improved glycemic control, there is complete resolution with weight gain. Some degree of weight loss may be present. Glucose tolerance test is an important investigation for patients with painful neuropathy. Insulin neuritis, first described in 1933 by Carbamazepine, it is an acute painful neuropathy which usually begins distally, may ascend proximally. There may be sharp shooting pains. It is associated with autonomic symptoms, gastrointestinal, genitourinary. There may be cardiac abnormalities, syncope, and even sudden cardiac deaths have been reported. There is no associated weight loss. Sensory symptoms are either absent or minimal. Complete recovery occurs within 1 year. Initially described with insulin, subsequently it was found that it is associated with oral hypoglycemic agents or tight dietary control to reduce blood glucose level. It is associated with rapid loss of rapid glycemic control, and for this reason, this is also known as treatment-induced neuropathy of diabetes rather than insulin neuritis. This is the most common presentation, distal symmetrical sensory motor neuropathy. The patient usually presents with sensory symptoms which ascend from the toes proximally. When it reaches the level of knees, the fingertips are involved. This is associated with other complications of diabetes, such as retinopathy and neuropathy. In a patient with diabetes, if there are clinical abnormalities, autonomic abnormalities, a diagnosis of DSDP, that is sensory motor neuropathy, is invariably present. It is insidious onset, developed over months to years, and it is a progressive course, irreversible. Symptoms, these are the important symptoms, but they develop from the toes and they ascend up. And signs also are, they have a distal emphasis. Cranial neuropathy. Patient suddenly presents with retroorbital pain and third nerve palsy, which is the most common. Other nerves involved are 4th, 6th, and 7th cranial nerves, which are not painful. Ocular motor nerve, that is third nerve palsy, is abrupt in onset, associated with retroorbital pain. Ptosis and ophthalmoplegia is there. The eye is rotated outwards, and there is sparing of pupil, but at times the pupil may be involved, and hence MRI angiography of brain is indicated to rule out any aneurysms. Entrapment neuropathies, carpal tunnel syndrome is most common, said to occur in 30% of diabetic patients. The hands are involved, especially the thumb and index finger. Other entrapment neuropathies are ulnar nerve, where the little finger is more involved. Similarly, popliteal nerve may be involved, and the lateral cutaneous nerve of the thigh, giving rise to myalgia paresthetica. This is an important syndrome, though rare, not so common. It occurs in both types of diabetes, type 1 and type 2, with poor glycemic control. There is severe pain which begins in the low back, radiates into the thighs. Over a month or two, the pain goes to the other side. It is associated with marked atrophy of the thigh muscles. The atrophy may spill over to distal location also. The ankle jerk and knee jerks are diminished. Is thought to be it is due to microvascular microinfarcts in the nerve fascicles. Clinical diagnosis is often straightforward, but given the fact that the pain is severe and there is marked weight loss, neoplastic process or lumbosacral radiculopathy lumbosacral disease should be ruled out, and hence CT pelvis, MRI, LS spine, etc. indicated. EMG is important in that the EMG features reveals, in addition to the other features of DSDP, that is distal symmetrical polyneuropathy, fasciculations, positive sharp waves are seen in lumbosacral muscles also. Treatment is control of blood sugar, pain, such relief with NSAIDs, even opioids may be required, and regular physiotherapy. It carries a almost guaranteed recovery, full recovery with time. Truncal neuropathy is thought to be a formis fructis of the previously described Bruns-Garland syndrome, abrupt in onset, like that of the previous one, but here the symptoms are located in the chest or upper abdomen, and myocardial disease, acute cholecystitis, acute appendicitis has to be ruled out. Is worse at night. All diabetic neuropathies, painful diabetic neuropathies, are worst during rest or at night. There may be weight loss. EMG again shows paraspinal or abdominal wall denervation, that is sharp wave fibrillations. Spontaneous recovery occurs, but the recovery may be prolonged. Now I come to the clinical approach, what is called 3L approach. We must listen and then try to locate the listen. By listen I mean history. History is important. If the patient gives a history of symptoms and signs ascending from the toes and then moving proximally with involvement of the fingertips, we are dealing with a case of DSDP, that is distal symmetrical polyneuropathy. If the patient gives a history of oculomotor nerve palsy, then third nerve, fourth or sixth nerve should be ruled out. If the patient gives a history of truncal pain or lumbosacral pain associated with wasting, Bruns-Garland syndrome or thoracal radiculopathy should be ruled out. And the patient may present with entrapment symptoms, such as in the distribution of the carpal tunnel or ulnar and other locations, which I have shown diagrammatically. This is the typical distal This is the typical distal symmetrical sensory motor neuropathy. I have tried to highlight the concentrations of symptoms distally. As it moves up to the knees, the hands are involved. That is the typical thoraco-abdominal truncal neuropathy. And the lower part reveals the Bruns-Garland syndrome or lumbosacral radiculoplexopathy. Those are the entrapment neuropathies type C, carpal tunnel syndrome on the right side of the picture, and ulnar neuropathy in the left side. This is the typical distribution of ulnar neuropathy. And here, thumb and middle finger, there is carpal tunnel. This is tubular or pterygial neuropathy. And That is the typical distribution of autonomic neuropathy with involvement of the heart and GI and GU system I have shown. Next we come to look, that is to examine. This is the pain assessment scales widely used from 0 to 10 or no to worst possible pain. We try to ask the patient how much pain the patient is feeling, but this is after all a subjective test. Then we go for test sensory examination. We look for pinprick, temperature sensor, vibration sensation. Usually pinprick and temperature are involved earlier than the large fiber functions. This is the monofilament test. Those are the 10 sites that are to be tested. If there is deficiency in 4 out of 10, he has significant disease. This is the autonomic test. Though these are not widely practiced, if the patient gives a history of orthostasis, impotence, or GI disturbance, GU disturbance, then, and we should look, measure blood pressure in the supine and standing position to look for postural hypotension. This is the motor system examination, examining for ankle jerk, knee jerk, and examining for strength of the extensor hallucis toe muscles. These are the objective tests for painful diabetic neuropathy. Of these two, nerve conductance may be helpful. Painful diabetic neuropathy is observed by small fibers, which is not picked up in nerve conduction studies, which typically pick up large fiber only. And another important investigation now upcoming is the last one, intraepidermal nerve fiber density. Here punch biopsy is taken from a distal site in the feet and the thighs, and the small fibers density of the small fibers is measured and compared. Corneal confocal microscopy, where the eyes, the middle layers of the eyes are looked for small fibers, but this is also investigational at present. These are some of the investigations recommended regarding urine, fasting blood glucose, and hemoglobin A1C. You all know more than me. Vitamin B12 levels. Regarding this, I would like to mention that many of our patients of diabetes are on metformin, and metformin is an important cause of vitamin B12 deficiency. Management. Chronic pain, any chronic pain, including painful diabetic neuropathy, is associated with sleep disturbances, mood disturbances, isolation from social isolation. Therefore, the treatment has to be multimodal, and sympathy and empathy to the patients is most important. The first and most important control is the treatment of blood sugar. Blood sugar should not only be controlled, but the control should be maintained, because wide swings of blood pressure is also associated with acute nerve injury, which adds to the chronic injury that is already there. Next is the pain management. These are the important groups: tricyclic antidepressants. Another group is SNRIs or SSRIs. Both are antidepressants and anticonvulsants. Opioids are last choice. These are the recommendations. Tricyclic antidepressants. Among these, amitriptyline is most widely used. The recommended dose is less than 100 milligram, because beyond 100 milligram, cardiotoxicity, especially sudden death because of arrhythmias, are known. Amitriptyline, or for that matter, any tricyclic antidepressants, is arrhythmogenic for the heart and epileptogenic for the brain. Duloxetine is an upcoming drug. In some recommendations, it is first-line drug, up to 120 milligram. The principle with all these medicines is that one should start low and gradually build up depending on tolerance or efficacy. And similarly, pregabalin, up to 600 milligram we can use. Some studies report pregabalin to be the first choice. Gabapentin, up to 3,600 milligram we can build up, but usually if the patient responds, it is usually within 900 to 1,200 milligram. These are the drugs of which carbamazepine, though we use carbamazepine quite frequently and oxcarbazepine, they are more useful in lancinating pain rather than the distal symmetrical persistent pain of diabetic neuropathy. Lamotrigine, there is not much encouraging result. There are so many conflicting reports, so it is not so much used. Valproate is second-line drug, but its use is associated with so many side effects that we hardly use it. With all these drugs come side effects, so we must be aware of side effects. Tricyclic antidepressants, the important side effects are orthostasis. Diabetes patients already have autonomic neuropathy. If we give them antidepressants, they may develop postural hypertension, falls, and its associated problem. Another group is SNRIs, duloxetine, venlafaxine. They are relatively less. They have relatively less side effects compared to tricyclic antidepressants. But since they belong to the same group, side effects, some of the side effects are common. Gabapentin and pregabalin, they are relatively harmless, no major drug interactions, but sedation, peripheral edema, and cognitive clouding and weight gain is an important problem. These are topical agents which are used in desperate situations, but it is not practical. When there is localized pain, we can use topical lidocaine, capsaicin, but for wide area, we cannot. Tramadol of the opioids, tramadol is relatively safe. The dose recommended is 50 milligram up to 200 milligram, but one must remember the risk of addiction and that it lowers seizure threshold. Other narcotic analgesics, they are used in desperate situations, such as the Bruns-Garland syndrome or thoracic radiculopathies, because the pain is intractable, difficult to treat, but that is for short duration only because of the dependence and abuse potential. These are the non-pharmacological ones, but as I am already up, I have finished my time, so I am just mentioning it. Of these, transcutaneous electric nerve stimulation that was pioneered by a neurosurgeon is useful. Others are either experimental, highly invasive, or there is limited data. Complementary and alternative therapy, such as acupuncture, is also being looked into vigorously. Lignocaine patch I have already mentioned. Topical is okay. IV lignocaine is recommended. Opioids, morphine, tramadol, but tramadol is rather relatively safe, and tramadol and paracetamol is thought to be as effective as gabapentin. So other treatment options are there. Interventional treatment, these are highly invasive ones, not available easily. This is the chart, but for paucity of time, I am just mentioning a few words. We first must clinch the diagnosis of diabetic neuropathy, exclude other causes, begin drugs one by one, either when and continue it for about 1 month or so before we think there is no response or inadequate response. Help from pain specialists or psychologists may be required. If there is no response, then we can think of adding topical treatments. If no response at all, then consider non-pharmacological treatments. This is to say that we can give relief up to 30 to 50% of, we can relieve pain by 30 to 50%. No drug is available, no drug is available to cure this, and we have a lot more to do. Thank you.
Thank you, sir. Your prize question, please.
I have not prepared, but anyway, my prize question will be a simple one. Clinical features of painful diabetic neuropathy is all of the following, except number 1, the pain is lancinating, burning, tingling, or pricking, or the pain which is relieved at rest or during sleep. If you have listened to my, this is the answer. Answer is there. No. Again, first, pain is lancinating, burning, tingling, prickling, pain which is relieved at rest or during sleep. I have given the clue. Last one, yes. Pain is worst during rest or at sleep. Thank you.
Thank you, sir. Dr. Indranil Thakur from SSKM Hospital, Critical Care Medicine.
Sir, we have a small token for
Any question from the floor?
Congratulations. Congratulations.
Sir, thank you for the excellent presentation. I like to just ask one question. How do you see the combination of duloxetine and gabapentin in managing this patient?
Duloxetine and gabapentin.
gabapentin, sir.
Actually, I have rushed through the chart.
In combination, sir?
Yes. When first we add either tricyclic antidepressants or one of the anticonvulsants. Duloxetine is a SNRI. It is a tricyclic antidepressant, SNRI, serotonin norepinephrine release uptake inhibitor. It is an upcoming drug. According to some, it may be first-line drug. And when it fails or there is less response, then we can add gabapentin or pregabalin. Either we can, or even switch between the classes. The two can be used together and they are quite effective. Yes. Yes. In elderly patients, those who do not have strong antidepressant. Yes.
Problems. If we get some problem, you have to exclude some other causes, particularly the CIDP as an important mimicker, because
CIDP,
treatment strategy will be somewhat different.
CIDP, the presentation is altogether different.
Yes.
In CIDP, motor symptoms are more prominent, and the symptoms have a proximal emphasis, proximal and distal involvement. It is usually associated with a progressive course, but there may be intermittent relapsing courses. When there is significant motor involvement proximally, when the course is progressive, we should go for investigation to rule out CIDP. But the problem is that for CIDP, we do EMG NCB, but same changes may be seen in long-standing diabetes, diabetic neuropathy. Then we go for CSF study to look for albuminocytologic dissociation. But in diabetes also, the blood CSF protein may be high, up to 100 milligram. That also confuses the diagnosis. If we have a strong suspicion, it is recommended that we go for definitive treatment in the form of either prednisolone or IVS.
So treatment strategy will be somewhat different, I think, in that situation. Treatment will be different.
For CIDP, we recommend steroids.
Okay.
Steroids, but that may aggravate sugar problem.
Yes. Now, what about the foot ulcer? Has it got relation with the neuropathy? Foot ulcer, diabetic foot ulcer.
Foot ulcer, no? Certainly diabetic, I have already mentioned in my first, it increases the frequency of diabetic foot disease because the neuropathy makes the feet insensate. Injuries may be there. Even the arches are involved. There may be subluxations of the joints. These are all predisposing factors for diabetic foot disease, including ulcerations, gangrene and all. Microvascular changes, they contribute to it.
Thank you very much, Dr. Somani. Dr. Majumdar's question, that is CIDP. I think the CIDP start with fever, with acute onset, and then go on to CIDP. Chronic
usually
demyelinating.
AIDP, usually they have preceding infections, either GI, but they may develop without ulcer. And the fever or any infection usually occurs more than 3 weeks prior to this. But CIDP, there may be no precipitant. Diabetes itself once was thought, he is right, that it is CIDP is more common in what we read earlier. The CIDP is more common in diabetic patients. But nowadays it is believed no, there is diabetes that does not confirm increased risk to CIDP. And
differentiate
one
it
should
by
look
the-
for prominent motor symptoms. If motor symptoms are there, that is weakness,
motor symptom
which is
more.
proximal as well as distal. In diabetic neuropathy, for several years, the patients have symptoms. Signs are, sensory symptoms are there, but motor symptoms are not there. There is no weakness. The patient can move the toes and there is no problem with walking and all. That appears much later. Large fibers are involved much later in the course. So if a patient presents with proximal distal weakness, we should think of CIGP.
Whether
And-
it's possible to differentiate with by nerve conduction velocity.
The problem is that with nerve conduction studies also, in diabetic neuropathy, same changes may be seen. But if there is marked demyelination, conduction block, then one should be on guard for CIGP.
And for neuropathy, the patient's food complication is more in diabetes.
Diabetes.
That's why food ulcer is one of the causes neuropathy.
Neuropathy, yes.
Sense of-
And
That's-
because the feet are less sensitive, insensate we call.
Thank you very much. If there is no question further, we conclude the session here. Thank you very much, Dr. Somani.
Thank you.